morning, everyone. It is so nice that you were able to join us this morning. I'd like to welcome everybody here in person, but also acknowledge that we have a whole group of oncology nurses that are joining us virtually for this program also. So during the program, please feel free to enter any questions, and we're also going to be fielding questions from our online virtual participants. So this morning, we're going to be presenting Leading Change and Leading Advances in CLL Care, guidance on delivering modern targeted and cellular therapeutics. My name is Laura Zitella. I am a nurse practitioner at the University of California, San Francisco, and I am delighted to be joined by my esteemed colleagues, Christina Russomanno and Kristen Battiato. So we'd really like to thank PeerView for coordinating the session this morning, as well as the CLL Society, who was really integral in helping us develop the content and providing the very important patient perspective. We'd also like to thank AstraZeneca, Lilly, and Pharmacyclics and Janssen for providing the educational grants for the symposium. So if you haven't already, please do complete the pre-event survey and look out for the additional follow-up polling during the presentation. As I said, if you submit your questions through the iPads that are provided for you, we will answer them during our presentation and also during the Q&A session. So all of the slides and really excellent content in the practice aids can be downloaded, and the website is listed here, and you can refer to that throughout this presentation and afterwards for your practice. Let's start with a little bit of basics. Where do we stand with CLL in 2022? There are an estimated 18,740 cases for 2023, leading to 4,400 deaths. The median age at diagnosis is 70 years, so we know that this is the disease that most often occurs in older patients. And it's important to keep in mind that CLL and SLL are considered to be identical diseases. And the way I think about it is that it originates from the same cell, but it's called CLL if it's found predominantly in the bone marrow in the blood, and it's called SLL, small lymphocytic lymphoma, if it's found predominantly in the lymph nodes. It's treated exactly the same way, and the 5-year relative survival rate for adults with CLL is 88%. And that is a pretty significant survival rate for someone who has a malignancy, because although this is often an incurable illness, it is highly treatable. And we're going to talk about a lot of the modern therapies that we use to treat the disease this morning. So starting with an overview of the current landscape in CLL, it's changed dramatically over the last few years, where patients are no longer routinely treated with chemotherapy and are routinely treated with targeted therapy. So we have a number of agents that are BTK inhibitors, ibrutinib, which was first in class, and then newer second-generation agents, acalabrutinib and zanubrutinib, which are a little bit more selective and have a more favorable side effect profile than ibrutinib. These are all approved for CLL and SLL. Then we have a BCL2 inhibitor, venetoclax, which is also approved for CLL. And we have some newer agents that are right around the corner. Now, both of these BTK inhibitors and BCL2 inhibitors inhibit the B-cell growth pathway. And this is a very important mechanism of action because, of course, CLL is a malignancy of B lymphocytes. So what's up and coming are new BTK inhibitors with a slightly different mechanism of action, which we're going to talk about in a little bit, pirtobrutinib and nemtabrutinib. And pirtobrutinib is already now approved for mantle cell lymphoma, and we're expecting the approval in CLL very soon. So looking at the different targeted options and what the practice guidelines show, historically, we look at a number of different prognostic factors, and one of the more important ones is 17p deletion. And for patients who have CLL that carry the 17p deletion, and for CLL that doesn't have the 17p deletion, all of these targeted agents are effective in both settings. And then after first-line therapy, what we expect is that patients will enjoy a prolonged remission, but ultimately the CLL will relapse, and then we have a number of second-line therapies. And as you can see, they look very similar to the first-line therapies, and we're going to talk about how you can sometimes either retreat with the same medication, or you can opt to use a different targeted agent than you used in the first line. So for example, if you start with a BTK inhibitor and there is a relapse later on, you can consider using a BCL2 inhibitor like venetoclax. So despite all of these advances, the real-world data shows that work needs to be done. So there was a study looking at how the actual treatments that patients received between 2013 and 2021. And there has been a significant shift where, like in our practices, all patients are being treated with targeted therapy now. But in this study, it showed that there's still a significant number of patients throughout the United States that are being treated with chemotherapy or single-agent rituximab, which is not the standard of care at this time. So we know that we have so many effective therapies, and one of the most important roles that we play is effective symptom management. How do we help patients feel as well as possible while they're on these therapies to live as long as possible? And so prompt identification of adverse events and monitoring and treatment of symptoms is really important, and I think that's where we play a very special and unique role. So the most common adverse events that are seen in this setting are infection, bleeding, and diarrhea. We know that it takes a village to take care of patients, and we have a lot of different roles on the healthcare team: the hematologist, oncologist, the advanced practice provider, the pharmacist, and pharmacists are especially important in CLL since these are oral medications and often need to be ordered through a specialty pharmacy. There's drug-to-drug interactions that pharmacists can help us identify. We also have social workers that provide social support, and then of course the oncology nurse. And the oncology nurse is really integral in the team in patient education, teaching patients what symptoms to report, what side effects to expect, managing those symptoms, giving them tips, counseling on the treatment expectations. We're going to talk a little bit about the logistics of the targeted therapies and how we make the choice of using one over the other and how we talk to patients. And there's a lot of shared decision making because you're going to see that there's not always a right answer. And then finally, connecting patients with the really important resources that are available to help support them. So the CLL Society is an excellent resource for healthcare professionals, patients, and caregivers. So they put on educational programs such as this one, but they also have an incredible resource on their website for patients, such as patient education materials that you can print off and give to the patients about the different medications. They have some really innovative programs like getting a second opinion. Patients can contact the CLL Society and get a second opinion from a leading expert in the field, which is a really incredible resource, especially if patients are being treated in the community by a general oncologist, to have that second opinion can be really reassuring to them. There's also an expert access program where patients can ask questions, and CLL experts from across the country will give them advice. So I encourage you to look at these resources. There's a QR code and the website on this slide. So the most important person on the team, of course, is the patient. And so we wanted to bring a patient into our presentation this morning, and we're going to do this through a video. So I would like to share this video of the patient voice. This is Terry Evans, who's going to share his experience as a patient and advocate.
My name is Terry Evans, and I was diagnosed with CLL 22 years ago in 2000. At the time of my diagnosis, there were really only two options for treatment. One was chemotherapy, and the other one was transplant. When I finally needed treatment in 2007, the treatment options really had not changed, so my first-line treatment happened to be FCR, or chemotherapy. This began my next 15 years of treatments. I've had over 7 different treatment protocols, several of them more than once. The advancements in the treatment for CLL has been nothing short of amazing in the last 10 years, where I was extremely limited in my choices for treatment. Now patients have choices of several very viable options, depending on their age and their health status and the type of treatment they would be comfortable with. They can now choose from continuous treatment that keeps their disease stable or a fixed duration treatment. Both of these options have shown long-lasting remissions in the frontline setting. There are also now trials comparing various combinations of covalent BTK inhibitors, venetoclax and obinutuzumab, that will hopefully give patients even longer-lasting remissions. Patients should not neglect looking into clinical trials. I personally have been on 3, and I don't regret being on any of them. If you relapse on a BTK inhibitor, you can move to a BCL2 inhibitor and vice versa. If a covalent BTK inhibitor is used in the front line, there are generally 2 reasons to discontinue therapy. If the reason for stopping is because of disease progression, then moving to a non-covalent BTK inhibitor, which are currently in clinical trials, may be an option. Clearly, one of the biggest unmet needs for CLL patients is if you are double refractory to both a covalent BTK inhibitor and a BCL2 inhibitor. This is an area where non-covalent BTK inhibitors and possibly CAR-T may be an option for the patient. What has been invaluable to me in my journey with CLL are the resources that are available through the CLL Society. Whether a patient is interested in just learning more about CLL or joining one of the over 40 CLL-specific support groups, all that information is available on the website at cllsociety.org. This website has sections for newly diagnosed patients, for the types of treatments that are available, what tests should be run, and when they are necessary and unnecessary. I wish this resource were available to me when I was first diagnosed. Patients need to learn about what their treatment options are, if their status changes to needing treatment, or if they're relapsed on their current treatment. I am a 22-year CLL patient and survivor. I have some of the worst prognostic markers. Without these new treatments, I would not be alive today. Every time I needed a treatment, there was an option available to me. I have long ago realized that I may just be kicking the can down the road, but so far there's no end to that road in sight. Thank you.
Thank you. So our goals for today is to help you understand the evidence that supports established and emerging therapies for the management of patients with CLL and equip you with the skills that you need to integrate these targeted therapies and other options into personalized management plans for patients with CLL. So I think by the end of this session, we hope to increase your confidence in being able to counsel patients who have CLL on their disease, the prognosis, the difference between the agent classes, and the efficacy and the safety expectations. And hopefully you're going to find some practical guidance such as dosing, scheduling, care coordination, monitoring, and managing the adverse events. So with that, I would like to turn it over to my colleague Christina, who's going to talk to us about covalent BTK inhibitors.
Good morning, everyone, and thanks again for joining us. Before I get into the first slide, I just want to make mention that the BTK inhibitors are oral therapy. So again, as Laura said, game changer. As of 10 years ago, the only option for these patients was chemoimmunotherapy. And a lot of patients did pretty poorly with this. So when the BTK inhibitors came along, it was a game changer for the CLL patients. So this slide here kind of looks at the efficacy of continuous BTKI therapy. So to prove efficacy, we have to take the standard, which was chemoimmunotherapy, and then compare. So each one of these studies compared a BTK inhibitor with some form of chemoimmunotherapy, and across the board, there was a progression-free survival benefit with the BTK inhibitors. For an example, with the Alliance study, of 48-month PFS estimates were 76% for ibrutinib versus 47% for bendamustine Rituxan. So even any patient looking at that is going to think that's significant. Also in these studies, they proved that these patients that had these riskier or adverse genetics were, they actually had extended PFS as well, which they did not with most chemotherapy. And so I know we talked with Laura a little bit about deletion 17p, and we're going to kind of hone in on that as a poor prognostic factor. And these patients even in these studies, they had improvement in their PFS. So TP53 and 17p mutated and or deleted, again, adverse risk factor for these patients. IGHV status unmutated. And I'm going to kind of, for the purposes here, I'm going to kind of group those two together. So what does it mean that it's an adverse risk factor? So basically, this means that these patients have more aggressive disease, they have shorter time to therapy, they don't respond as well, they have shorter periods of time between therapy. Also, we look at beta-2 microglobulin greater than 3.5, higher clinical stage, and age greater than 65. This is mostly because these patients have more comorbidities once they hit 65 and above. There is no role for chemoimmunotherapy in deletion P CLL. So what is the efficacy of BTKs in deletion 17p CLL? So back to these same studies again. If you look at the center line, it shows how many patients with deletion 17p and or TP53 mutation were included. And again, there was a PFS benefit for these patients, as I said a little bit earlier. So some of these, they didn't even reach a median PFS. So the CLL Society does encourage patients to obtain biomarker testing before receiving treatment. And I sit up here from a major medical center, and this to me is, of course, like, it's expected, it's normal, it's what we do all the time. But is it in the community and other places? Maybe not. And some of these patients are unaware of certain tests that should be done before they receive treatment or even when they're moving on to a second line of therapy. And so what the CLL Society did was they put together a test before treat campaign, which basically educates the patients and then empowers these patients to go to their providers and say, oh, I didn't have this testing done, can you do it? Or, oh, did I have it done? Can you sit and explain what this means to me? Because we use these results to guide therapy. And so these patients want to know more about their specific CLL. And so if we look at the test before treat, and again, you can also use this QR code to pull it up, so we test FISH and TP53 mutation before every treatment. And this is because it can change after you receive therapy. We test IGVH mutation status before the first treatment. No need to retest that. That does not change. And then deletion 17p, TP53 mutation, no chemotherapy. And I can kind of summarize the rest by saying no chemotherapy. The reason that IGVH mutated says possible FCR is because there is a subset of patients with great prognostic features, so they have a mutated IGVH and a 13q deletion. And these patients actually can respond to FCR, and we have some patients 10, 15, 20 years out who still have a durable remission from this regimen. So we do have to mention it. So dosing of our covalent BTKs. So we have 3 now in CLL. So first to market ibrutinib, 420 milligrams once daily. This does differ from mantle cell lymphoma dosing, which is 560 milligrams. Imbruvica has the most dosage forms available. Acalabrutinib, 100 milligrams twice daily in tablet formulation, or zanubrutinib, which can be given either 160 milligrams twice daily or 320 milligrams once daily, and those are in capsules. So when we're starting therapy on these patients, we obviously need to review dosing with them, let them know how they're supposed to take these drugs. And this is a little bit complicated, this slide, but what this is basically telling us is that there are interactions with these drugs and other drugs. And so what you want to do is you want to make sure that you're checking drug interactions. And we're all nurses, and this is what we do. So this is not new for us. So when you're going to start therapy, you'll run drug interactions. You'll make sure there's nothing that's going to be a significant issue. Every time that patient comes back in the room and tells you that, oh, my cardiologist started a new med, my psychiatrist, you're going to, again, check, because you're not going to rely on that other provider to have checked for you. There is dosing and drug interaction information is available as a downloadable practice aid. So if you want to keep this for reference. So what are the possible AEs that may arise with the BTK inhibitors? So these are kind of it's a class effect, right? So we talk about these in regards to all the BTK inhibitors, and you're gonna go through these with your patients. So atrial fibrillation, obviously a cardiac arrhythmia, one of the ones that will concern them the most when you mention it. You really want to make sure your patients are aware of the possible signs and symptoms of atrial fibrillation so they can possibly identify and seek help if they need it. Some will be like, my Apple Watch now told me I'm an AFib. That's new. So, they have some hint there. Or they'll come into the office, you'll do an exam, and you find the AFib, and they're completely asymptomatic. Arthralgia is one of the more difficult to actually manage. Joint pain, but I can also group in here myalgias, right? Some of these patients have muscle pain and muscle cramping as well. Higher risk of infection. These patients are already at a really high risk for infection, and now we're adding some therapy, so we have to be really cautious. And we know the sinopulmonary infections are what really plague our CLL patients. Diarrhea, I personally do not see this that often, but I do educate patients that when you start the therapy, you might have some. A few instances is fine. Try to hydrate. But if it's persistent diarrhea, I need to know about it. Hypertension, another one that will concern your patients, and usually a side effect that comes along a little longer into therapy. But you have to tell these patients you might need an antihypertensive at some point in your treatment. If they're already on antihypertensives, they might need to increase their dose or start a second agent, and you just want to prepare them for this. And some of them have cardiologists, and you can work in conjunction with them. Bleeding risk, so we know these drugs thin the blood. They act a little bit like an aspirin, so higher risk of bleeding for these patients. You want to warn them they'll have easier bruising. They might have some petechiae. We want to know before any invasive procedures they're going to have, because we need to guide them on when to hold the drug and when to restart, right? So we mitigate bleeding risk for these patients. Obviously, the other thing we usually mention is if there's any significant trauma, you obviously need to be examined. Derm changes, so you can get some rashes, but really the thing patients complain most about are brittle and frail nails and thinning or some hair loss. And that's where we usually look with the derm. Fatigue, difficult because some of these patients are going in fatigued, like they're anemic. And then what I usually say is sometimes the fatigue can worsen before it improves, and it should get better with time on therapy. Ventricular arrhythmias, these are rare, you do have to mention they could occur. And cytopenias, and as we all do, we will measure CBC, we will monitor CBCs. So what are the implications of BTK inhibitors, selectivity for off-target effects? So basically what this slide is showing is that first to market ibrutinib was the least selective of all the drugs, right? So it hit more off-target effects, and therefore it has a poorer side effect profile. The newer second-generation drugs, acalabrutinib and zanubrutinib, they perfected this a little bit, and so now they hit less off-target effects, and therefore they have a better side effect profile. They're better tolerated by the patients. There were head-to-head trials that went on to compare the second generations like acalabrutinib to the initial ibrutinib. And as you can see, this is pretty significant data. So this is median follow-up of about 41 months. So AFib, A-flutter, 9.4% in acalabrutinib versus 16% in ibrutinib, 9.4% hypertension versus 23% in ibrutinib, and again, bleeding risk as well, 38% in acalabrutinib versus 51% in ibrutinib. So this is pretty significant difference. Also, Alpine study looked at zanubrutinib, our other second generation. In their safety analysis, it was noted 5.2% had AFib, A-flutter with zanubrutinib versus 13.3% ibrutinib. So our general safety considerations with BTKs, and again, this might be repetitive, but it's so important. Bleeding, we're going to monitor for bleeding. We're going to notify the patients of what to watch out for. A lot of these patients are on anticoagulation. That's okay. It does not mean you cannot be on a BTK inhibitor. We just need to monitor you closely. We really want to try to avoid warfarin. It's just it's annoying to actually manage warfarin at baseline and now add this in. And then we want to let the patients know, of course, notify us when you're going to have a procedure, notify us of any bleeding. Infections, monitor, patients call, evaluate them promptly. Obviously, you want to get on top of infections. Cardiovascular events, evaluate your cardiac history. Do they have any medications they're taking normally? And I know a lot of us, before we start this therapy, will do some kind of cardiac evaluation. Commonly in the practice I'm in, we do echocardiograms. We want to see where we're starting, right? We want to make sure everything's okay. We're going to teach these patients to monitor for arrhythmias. We'll monitor hypertension. Patients should monitor blood pressure. We'll monitor at visits, manage with antihypertensives, and cytopenias. We will check your blood counts. So I talked about kind of the class side effects, but the second generations have some specifics. So acalabrutinib, there is a possible side effect of these headaches. They commonly occur earlier in therapy with acalabrutinib and typically resolve in 1 to 2 months. And we manage these with Tylenol and caffeine, which is very, very effective. I don't know a single patient that's had to come off this drug for headaches, but sometimes you do have to provide some emotional support to get them through. We mentioned caution with ibuprofen and NSAIDs due to increased risk of bleeding. That said, I just told you, you can be on an anticoagulant. So this is just a caution. We don't want them taking 800 of ibuprofen every 2 hours. Zanubrutinib, there's a risk for neutropenia, more so than with the others. And so, of course, we don't want our patients neutropenic. How this is managed in practices is a little different, so nothing is wrong, but in the practice I'm in, we usually start with some growth factor. We'll give them, and we'll see if, was this a one-off, can we boost them up and move along? Obviously, if they have persistent neutropenia, we're gonna have to evaluate. You don't wanna live on growth factor, and you don't wanna live neutropenic. So at that point in time, you might have to stop the drug for a period of time and let the patient recover, or you might have to actually consider dose reduction. So what are our take-homes on continuous BTK therapy? Before starting BTK therapy, we're going to fully evaluate our patient. We're nurses. This is what we do. We'll assess for comorbidities. We'll evaluate their risk factors. We'll talk them through if they don't understand. We can kind of talk to them about why we picked the therapy we did. Educate on dosing and the expected AE profile, which we just did. Watch for intolerance. So we really do try to get our patients through these side effects, right? We're going to try everything in our power to get them through before we consider changing. So the thing is, if you're on ibrutinib, which is the first generation with the poor side effect profile, and you've tried every option, you can't help them through their side effect, you can actually switch to a more selective covalent BTK and see if that helps to mitigate the side effects. And we're going to be prepared for multidisciplinary collaboration. So these patients have other providers. We need to work together, especially cardio-oncology, dermatology, pulmonology, right? So we have to just work as a team. So on your iPad and virtually, we would like you to answer some questions on your understanding of BTK safety profiles and managing BTK AEs. And now I'd like to introduce my colleague, Kristen, who will talk about non-covalent BTK inhibitors.
Thank you. Good morning, everybody. Thank you for getting up at the crack of dawn with us. I'm going to talk about non-covalent BTK inhibitors and how nurses can prepare. So with covalent BTK inhibitors, resistance mutations are the major driver of progression in CLL. The BTK CYS41 mutation is the dominant reason for progressive CLL in patients receiving BTK therapy with covalent BTK inhibitors. And we've seen that patients who've required ibrutinib resistance, the majority of them have had mutations in BTK and PLCG2. Let's define double refractory disease. This is an unmet need in our patient population as they continue to live longer and proceed through more and more therapies. So the proposed criteria for defining a double refractory CLL patient is as a patient treated with a BTKI and venetoclax-based therapy in any line of therapy. They've had clinical progression while on a BTK inhibitor. They've had clinical progression while on venetoclax within 24 months after venetoclax discontinuation or being resistant to treatment with a venetoclax regimen. Double refractory patients are a subset of double exposed patients and have a very poor prognosis and suboptimal standard of care options at this time. The median time to discontinuation of the next line of therapy or death was about 5.5 months for this patient population. Non-covalent BTK inhibitors can overcome BTK resistance. So covalent BTK inhibitors, like we just spoke about, ibrutinib, acalabrutinib, and zanubrutinib, bind to BTK via the cis481 binding site. If this site mutates, the covalent BTK inhibitors can no longer bind to BTK, and the patient will eventually have disease progression. Pirtobrutinib is a new non-covalent BTK inhibitor and is a very exciting drug. It's non-covalent and does not rely on cis481 to bind to BTK. Therefore, it can overcome the cis481 resistance, and patients can have clinical response on pirtobrutinib despite the cis481 mutation. The covalent BTK pirtobrutinib is highly active in BTK pretreated relapsed refractory CLL, SLL patients per the Bruin trial. There was an overall response rate of 82.2% in BTKI pretreated patients with CLL and SLL. The median progression-free survival was 19.6 months, and there was durable efficacy regardless of the cis481 mutation status. Pirtobrutinib is also effective in patients with prior exposure to both BTKI and BCL2 inhibitor therapy. The overall response rate was 79% in BTKI, BCL2 pretreated patients with CLL, SLL, and the median progression-free survival was 16.8 months in patients with double exposed disease. Pirtobrutinib also has a really phenomenal AE profile. The most common grade 3 AE we've seen was neutropenia, which can be easily managed with growth factor support. I also want to highlight this is a BTK inhibitor, so you're going to be looking out for those BTK classic class side effects, and they include bruising, rash, arthralgia, hemorrhage, hematoma, hypertension, atrial fib, and atrial flutter. I do want to highlight there's a very favorable cardiac profile with this medication. Only 2.3% of patients developed grade 3 or higher hypertension, and 1.2% developed atrial fib and a flutter. Non-covalent BTKI dosing and safety. So based on the mantle cell label and experience in the CLL, SLL Bruin trial, the dosing is 200 milligrams once a day. We want to make sure you're monitoring for arrhythmias, infections, bleedings, and cytopenias, and look for any potential drug interactions. You want to avoid strong CYP3 and 4 inhibitors, and unless absolutely necessary, then you want to consider a dose reduction. And you also want to strong to moderate CYP3A4 inducers. If unavoidable, you'll have to consider a dose increase. So here are the major ongoing trials with non-covalent BTK inhibitors that are open to enrollment at this time. I want to highlight the Bruin CLL 322 trial, which we're currently enrolling at both Columbia and MSK at this time. It's pairing pirtobrutinib with venetoclax and rituximab versus venetoclax rituximab in previously treated CLL, SLL patients. The CLL Society can be very helpful in helping patients navigate clinical trials. They provide guidance on how to understand the importance of clinical trials and navigate clinicaltrials.gov. It provides step-by-step guidance on searching for all available clinical trials with those at SLL and CLL. And you can learn more if you scan this QR code. So nurse take-homes on preparing for non-covalent BTKI. Resistance to covalent BTK inhibitors is one of the drivers of progressive disease and treatment discontinuation. Patients with double refractory CLL historically have had very poor outcomes, And this non-covalent BTK class represents a significant contribution to CLL care, can overcome BTK resistance, and are effective in treating double refractory disease. It's still investigational, but open via trial enrollment at this time. Pirtobrutinib is approved in mantle cell lymphoma, and off-label use may be a possibility. All right, so now we're going to test your knowledge on your iPads. We want you to go and answer a couple of questions on the non-covalent BTKIs in CLL and counseling patients and access to non-covalent BTKI therapy. And I'm going to hand it back over to Laura.
Okay, so we are going to talk a little bit now about fixed duration platforms. So we spent some time talking about the continuous treatment with BTK inhibitors, which is taking oral medications every day. We have some options now where patients can have time-limited therapy. And so I want to start this section with that. So this is where shared decision-making is really important, and where we have a lot of long discussions with patients about the potential benefits and the side effects profile of the available options. So the one option can be taking pills every day indefinitely. Other options can be these fixed duration therapies. And the most common fixed duration therapy, the one that's approved right now, is venetoclax and obinutuzumab, which is a year-long of therapy and can provide a very prolonged progression-free survival and the possibility of undetectable minimal residual disease. So you can get a deeper remission with these fixed duration regimens than you can get with the oral continuous BTK inhibitors. But it's very different, the logistics, and we're going to talk a little bit about that because obinutuzumab and venetoclax regimen is very time intensive when it first starts. There are frequent visits, sometimes a couple times a week for tumor lysis monitoring, versus the BTK inhibitors where once patient starts therapy, you can check labs like weekly at first, ultimately monthly, and then after they've been on it for years and they're totally stable, you can often only check like every 3 months. So there are a lot of considerations. There's consideration if a patient is close to an infusion center, if you're seeing someone as a second opinion and they don't have an infusion center that's comfortable giving obinutuzumab, which carries a risk of infusion reaction. So there's a lot of things, and these are the conversations that we're having with patients to decide what is the most appropriate. And Christina also mentioned the importance of looking at comorbidities. So sometimes there are other medical problems will also influence our decision about the initial treatment. But I think one other important point that we're going to touch on is it is nice having options, because even if no matter what option a patient starts with, whether they start with a BTK inhibitor or a fixed duration regimen, we expect they'll enjoy some time in remission, but ultimately there will be a relapse, and then we can always move to a different class of agents. So over time, especially as our patient Terry pointed out, patients will ultimately probably be on every class if they're eligible for it. So just to review the evidence we have for the fixed duration regimens, it was the CLL-14 trial that looked at patients who were over the age of 70 and had comorbidities. And as Christina said, historically chemotherapy was the standard of care. So a lot of these trials that we've presented are comparing the newer agents against chemotherapy. The current clinical trials are not doing that, but this CLL-14 trial looked at venetoclax and obinutuzumab versus chlorambucil and obinutuzumab in first-line therapy for CLL, and there was a significant progression-free survival benefit that you can see 62% versus 27%. So that was really significant that the majority of patients will still be in remission at 5 years after this treatment. knowing that this treatment is only given for 1 year. And so they remain off therapy in remission. The other important data from this study is that you can look for minimal residual disease. And in CLL, there's a number of ways of doing that. But one of the ways that you can do it is through a special flow cytometry or using next generation sequencing to identify a specific DNA sequence that is only specific for the CLL cells. And using this, you can check it at baseline, and then you can check it again after therapy. And what they saw in this study is that 3 months after the end of treatment, there was a significant rate of completely undetectable disease. And some of these measures, this shows you looking at 1 in 10 to the -4, but we use even more sensitive MRD testing now that can test for like 1 in 100,000 or 1 in a million cells in the body, and we're seeing very high rates of minimal residual disease. So this regimen is extremely effective. Another fixed duration venetoclax platform was the Murano trial, and this was a trial that enrolled patients who had relapsed CLL and used venetoclax and rituximab. And again, there was a sustained progression-free survival using the venetoclax and rituximab versus rituximab and bendamustine chemotherapy. And what's interesting about this is this trial was done first, and in this trial, they started with venetoclax and then did rituximab, so they did a venetoclax ramp up first. And what we learned from this is that it is easier to start with, when you have a doublet with venetoclax, it's easier to start with the other agent first, and that decreases the risk of tumor lysis. So with venetoclax and obinutuzumab, you start with the obinutuzumab first, and then you bring in the venetoclax on day 22. And that has made it a lot easier to manage tumor lysis. So this is the schema of the venetoclax dosing and administration, and this is really important. It is complicated. Well, I shouldn't say it's all that complicated, but it is complicated to put together the calendar and make sure patients understand it. The way that the medication comes is very easy to use, and it's really nice. You can see the pictures here. In the starter pack, patients actually will just get week 1, and you open up the package and you just take the pills that are in there for week 1, and then for week 2, week 3, week 4. So it's very patient-friendly, and that part is easy to understand. What's complicated is, from our point of view, is before you start venetoclax, it is extraordinarily important to assess for the risk of tumor lysis. And based on the risk, if there's a very high risk, patients need to be admitted. If there's a low or intermediate risk, then we can treat as an outpatient. And in a couple slides, I'm going to talk about some of the other things that you do. But there's coordination of checking the labs, and especially with the 20 milligram and the 50 milligram ramp up. So after this ramp up has been completed, then the standard dose is 400 milligrams a day. So just like with the BTK inhibitors, there are drug-to-drug interactions with venetoclax, and you can see that it's important to avoid strong CYP3A inhibitors. If they do need to be used, there is a dose adjustment required. So one of the unique adverse events with venetoclax is neutropenia. And with neutropenia, again, there are guidelines on how to manage it, but there's also some clinician preference in there. So you could interrupt the dose for a couple of days and then restart. You could interrupt the dose and give growth factor. You could try to give growth factor and treat through. It just sort of depends on the patient, on the situation, where they are in the ramp up. So for tumor lysis monitoring, there's really good guidelines on how you determine the risk, if it's low, intermediate, or high risk. And you can see on this slide here, the important thing is the level of tumor involvement. And so what is important to know is the size of the lymph nodes and the absolute lymphocyte count, because that is going to inform us about the risk of tumor lysis, and we'll be able to stratify. So again, high-risk patients do need to be admitted for IV fluids and intense monitoring. The low-risk patients, though, that we see outpatient, we can check labs the day before they take the dose, the day that they take the dose, 6 to 8 hours after the dose, and then the day after they take the dose. And this is done at least for the first 2 weeks for the 20 milligram and the 50 milligram ramp up. In addition to that, patients need to be on allopurinol for prevention of hyperuricemia. And if patients are at high risk and they have an elevated uric acid to start with, respiricase can also be an option. And then lastly, it's important to counsel patients to be well hydrated. They need to be drinking at least 2 liters of fluid a day. So other adverse events that we see are GI events. There can be nausea or diarrhea. There can be infection. Upper respiratory is the most common. Sometimes we also see a cough that's a non-infectious cough that is related to venetoclax. Rarely there is an autoimmune hemolytic anemia, and it can cause joint pain. Okay, so moving into what's up and coming, this is not approved right now, but I wanted to let you know that this is on the horizon. There was a Captivate trial where they looked at combining ibrutinib, so a BTK inhibitor, with venetoclax to see if it was possible to do a time-defined therapy using both of these agents up front. And this strategy achieved durable responses, a clinically meaningful progression-free survival, and treatment-free remissions. So this was nice because it was a fixed duration of therapy, and it still achieved prolonged remissions. And again, just like with the other studies, it was effective in the high-risk groups, like patients who have CLL with the deletion 17p. Now, we talked a lot about tumor lysis with venetoclax. So the way this trial was designed is it was designed where you start with ibrutinib first, and you do 3 months of ibrutinib to lead in. And that effectively cyto-reduced the level of CLL and reduced the severity of tumor lysis syndrome. The most common high-grade adverse events were neutropenia and hypertension, but overall it was fairly well tolerated. I think what's important is it was highly effective, but now you have to look at the side effect profile for a BTK inhibitor and the side effect profile of venetoclax. So certainly with any doublet, there is going to be a more significant safety profile. So what does this mean for us? How are we going to prepare for the novel combinations? Well, as I mentioned, we need to now know the side effect profile for BTK inhibitors and educate patients about those potential symptoms, as well as the side effect profile for venetoclax. And both of these medications are oral. They're taken at home. They're usually delivered from a specialty pharmacy, and they're very costly. So the CLL Society has financial assistance programs, and there's also other financial assistance programs that can be really helpful to help our patients afford these medications. And then education of the patient and caregivers, and using the resources that we have so that patients are empowered to report any symptoms to us. So one of the really important resources that I wanted to point out was this education toolkit. And you can kind of see here what is available. There's a lot of information about each targeted therapy, and we know that when we're educating patients, it's very helpful and more effective if not only we're giving verbal education, but also written education that they can refer to later. So on your iPad and virtually, I would like you to take a minute to answer some questions on the evidence supporting fixed duration BTK inhibitors and venetoclax platforms. And hopefully you will answer that your confidence is now increased in your ability to manage TLS with these combinations.
I'm back. I'm going to talk to you guys about an investigational option for our double refractory patients, CAR T cells. So with CAR T cell therapy, we see a constellation of inflammatory symptoms related to T cell engagement and expansion. We can see cytokine release syndrome, neurologic toxicity, tumor lysis syndrome, B-cell aplasia, hypogammaglobulinemia, it's a mouthful, and cytopenias. The severity is usually related to disease burden and correlates with T cell proliferation. It can be mild to severe, leading to multi-system organ failure, typically occurring 1 to 14 days after CAR T cell infusion, and we'll often see an elevation in inflammatory markers with a massive elevation in IL-6. CRS, or cytokine release syndrome, presents with fever, fatigue, myalgia, arthralgia, headache, anorexia, nausea, vomiting, hypotension, capillary leak, coagulopathy, pulmonary edema, cardiac or renal dysfunction. So these patients can get quite sick. The goal is to prevent multi-system organ failure, but do not stop those CAR T cells from working. Treatment is supportive care. If the patient is decompensating, you'll try tocilizumab first, which is a monoclonal antibody to the IL-6 receptor, which blocks the IL-6 mediated inflammatory effects. And if the patient continues to decompensate, you'll then reach for steroids if they don't improve on the tocilizumab. We also see a lot of neurotoxicity and concurrent with cytokine release syndrome as well. This can present as confusion or delirium, expressive aphasia, seizures. Patients can have tremors, decreased level of consciousness and hallucinations, encephalopathy, and difficulty finding words. Cause is unclear, but usually cytokine and T cell mediated. Risk factors are unclear, but usually correlate with high disease burden and concurrent cytokine release syndrome. Treatment is supportive care and KEPRA, and you usually have your neurology service following along with you while they're inpatient, and sometimes outpatient as well. So I want to highlight a clinical trial, the Transcend CLL-004 study. These patients received anti-CD19 CAR with lysocell CAR T cells. There was an 82% overall response rate in heavily pretreated patients, and the median progression-free survival was 13 months in patients progressing after both BTKI and venetoclax therapy. We did see some toxicity with these CAR T cells. 74% of patients experienced some form of cytokine release syndrome, but I want to highlight that only 9% were grade 3 or higher. There was also some neurotoxicity patients saw. 39% of patients had some form of neurotoxicity, but only 22% had grade 3 or higher. So treatment with lysocell met its primary endpoint of complete response rate in patients with relapsed refractory CLL. And this is a potential option for patients, investigational option for patients who are double refractory with limited options for treatment. So we'd like to refer you back to the CLL Society. They have a lot of great information for you. They have a free CAR T cell brochure for patients and healthcare providers. They explain CAR T cell therapy to those with CLL in patient-friendly terms. They can be viewed as a digital flipbook online, and there's a free hard copy printed brochures that are available to have on hand in your office for distribution. You can just scan this QR code below. Okay. And I'm going to kick it back to you, Laura.
Okay, so now that we have gone through all of the data, I want to bring it back to Terry, and he's going to share his experience on the role of nurses.
Throughout my journey, nurses have been a major component of my treatment care. I must admit that I'm slightly biased here because my wife is a nurse, but more importantly, she recognized a serious condition that was not acknowledged by my first medical team, and because of that, she made me change doctors, which actually saved my life. I've also found that sometimes your best avenue of communication with your medical team is through the nursing staff, whether it was the doctor's nurse, the clinical trial nurse, or the nurse doing the bone marrow biopsy on you. They have all provided exceptional patient care. For nurses in the audience, I would say that attending events like this are very important. They provide an opportunity for you to find out about the latest advancements in treatment, learn from your expert colleagues, each other, and patients, and then use what you've learned to adapt to your practice to help patients with CLL like me.
Okay, so now we're going to move into our cases, and I think we're going to be able to answer a lot of these questions as we go through the cases. So we're going to start with the first case, choosing upfront therapy. This is a case of a 73-year-old patient presenting with symptomatic, higher risk CLL that has not yet been treated. There's a good performance status. The CLL has an unmutated IGHV and a TP53 mutation. So this is a high-risk situation. And the comorbidities include renal insufficiency. So I'd like to engage Christina and Kristen in, and we'll start with Christina, how would you counsel this patient? What do you talk to them when they see these mutations and they know this is high risk and they're asking questions about it? Tell us how you deal with that.
Yeah, and we're well aware that sometimes nurses, this doesn't fall under nursing realm, and some nurses might be a little bit uncomfortable discussing these, but it's also really important to educate yourself on these because the patients, we know they come to us with questions. And so basically knowing unmutated IGHV and TP53 mutation, these are poor prognostic features. And so we don't want to sugarcoat anything for patients. We want to be upfront and honest with them. But the good thing is what we can do is highlight the fact that therapy has improved so much over the past 10 years that now we've improved progression-free survival rates for patients with our novel agents. And other than that, we would just help them through the course of treatment once they needed it.
Yeah, I'd like to echo Chrissy's comments. I would just educate these patients that, both BTK and venetoclax-based therapy provide excellent disease control for these higher risk genomic features. And people have been able to have excellent disease control for many, many years to come. So there is really no wrong choice here, but, we might favor continuous BTK suppression of the clone because we tend to see these patients have a little bit more of a durable remission than those with the venetoclax time-limited therapy and the higher risk patient population. But again, venetoclax-based therapy is a totally reasonable upfront option for this patient as well. Just have to be a little cautious with the renal insufficiency, which we can talk about in a bit.
Yeah, I think that's a really good point, and thanks for leading right into that. So at the beginning when you're talking to patients and you're thinking about this, I think one thing you said that's really important is a lot of clinicians with older patients do favor starting with a continuous therapy, especially with higher risk disease, with this idea that continuous therapy could possibly keep them in remission longer. We don't have that data, and so a lot of this is basically experience and expert opinion. But in our center, that plays a role in our choice as well. And then the other thing in this case is renal insufficiency. So that does concern me a little bit, especially when you're thinking about someone who doesn't have very good kidney function. They're 73 years old, and we don't have any other information, but if they had a high lymphocyte count or a really bulky lymphadenopathy, that would put them at higher risk of tumor lysis.
Correct.
So when you're talking to patients initially, are there any other things that come up in your discussion?
Initially, just when counseling with BTK inhibitors, Again, I'll highlight, the excellent disease control, the convenience of it when compared to the time-limited therapy. It doesn't have as an extensive schedule. The monitoring in the beginning, usually patients will come in about once a week, and in my practice is how we practice. We'll get, weekly labs for the first month. And that's an opportunity for us, for at least our office practice nurse or for me, to check in with the patient and make sure there's no AEs that they're having, and we can help, talk them through that. And usually, we would just counsel them, even though the tumor lysis risk is very low in BTK inhibitors. Usually, we would start our patients on allopurinol just as a prophylaxis, usually for about the first month of therapy, just to make sure there isn't any signs of tumor lysis. Sometimes patients can have really bulky disease, and we want to be overly cautious and protect those kidneys. And just making it clear that, new side effects should be reported promptly, counseling them on the bleeding risk, and just being supportive and letting them know that you're there, and we're going to help them get through this.
Yeah. Thank you. My practice is pretty similar too. One thing I would add is I always make sure to talk to patients about hypertension every visit. So some patients that we have been on BTK inhibitors for 5, 6, 7 years. I mean, they're very effective, and you can be on them for a long time. And we know that the risk of hypertension continues throughout time. And when you're on a medication and you're doing well, like 3 years later, a patient who develops hypertension might not necessarily connect the two. And so I try to always bring that up in follow-up visits and have them monitor their home blood pressure and tell them that we would want to start blood pressure medication, because there's really good data actually that if you treat the hypertension associated with the BTK inhibitors, it decreases the chance of having other cardiac problems too. So it's really important to treat the blood pressure. Great. So did we cover everything, Christina, or do you have?
I think so. I think at the practice I'm in, we do a lot of this very simple. We don't monitor as closely, I guess, with the BTKs. So traditionally what we do, we'll start a BTK. 1 week later, we'll get some labs. We'll review the labs with the patients. We might do a quick exam. These patients have rapid shrinking of their lymph nodes and their spleen on these drugs. So they feel almost an immediate response if they're bulky. We'll just go through that. And then after that, we usually see them monthly and eventually stretch out to the 3-month follow-up. So it's definitely not as daunting as a fixed duration regimen.
Okay, so let's move into the fixed duration regimen.
On that note.
Kind of talk about that. So this patient's 59 years old, has a higher risk CLL that has not yet been treated, and there's a bulky lymphadenopathy. Excellent performance status. The IgHV is unmutated, and there's no significant comorbidities. So through shared decision-making, if the decision is made to go to venetoclax or obinutuzumab, what are the next steps? We can start with you, Christina.
Okay. So next steps here are education, right? So we're going to start educating our patients on this because there's a lot to talk about. We're going to talk about how often we give this regimen, how often they're going to have to come to the office, the possible side effects of both of these agents. We're also going to talk about logistics with family and making sure you get back and forth and drinking lots of water and starting prophylactic protective medications like antiviral medications, allopurinol as we discussed before. So there's a lot of education that goes into the first steps, and there are a lot of steps in this process, but that's where I would suggest we start.
Yes. Completely agree with you. Another way our clinic would prepare from a medical perspective, I would want to get a really good tumor lysis risk assessment. There is a tumor lysis risk seen with when you're giving obinutuzumab and both venetoclax. And sometimes patients don't have superficial palpable nodes. They can be smaller, and then you'll scan them and they're hiding like a 14-centimeter conglomerate in their abdomen of lymph nodes. So you need to find that, and if you're dealing with something like that, that might alter the way you monitor the patient. You might even consider hospitalizing them for the first infusion of obinutuzumab in order for more frequent monitoring, more IV hydration, and it's just safer. So we'd want to get that, assess the risk for tumor lysis. That's very important. Again, you want to make them aware of the potential of infusion reactions with obinutuzumab. About over 60% of patients will have some form of infusion reaction. These patients should be prepared for that, especially on day one is their highest risk for developing an infusion reaction. I always counsel patients that, it's a split dose. So you give 100 milligrams on day one and 900 milligrams on day two. I said, if you can take the week off or at least a few days, it's exhausting. They're there long, like the majority of the day they're there, hours and hours. And they're gonna be exhausted. They're getting, high dose steroids, they're getting Benadryl, they potentially have fevers and feel quite unwell. So just kind of setting them up for what the first couple of weeks look like, and letting them know it's not forever, it's manageable. Once you get through that's the most difficult part of this process. And then we hope that it'll pay off in the end, and they can potentially come off therapy and have a durable treatment-free observation.
Thank you. Yeah, that's our experience too. And it's really amazing, even after that first dose of obinutuzumab, where you're only giving 100 milligrams out of the 1,000 milligram dose, you can see a rapid response. The patient I treated this week, the white blood cell count went from 60 to 5 with just that very first one. So it's very effective as cytoreducing. And I think that is important to know because you're doing the tumor lysis risk assessment before you start obinutuzumab, and you're not starting venetoclax until day 22. So they've already had several doses. So by the time you start venetoclax, you want to reassess the risk of tumor lysis because they might very well be low risk at that point.
I also wanted to stress something that I should have mentioned before, but these patients, so this regimen, this fixed duration regimen, is based on the CLL-14 study.
Less intense, and there are fewer visits. So I'm curious how you